Hello friends, this is a case of total laparoscopic hysterectomy and we will do vault suspension with the round ligament because this patient has grade 1 uterine prolapse. We can see ureter here, it is visible, and this is IP ligament, this is the external iliac artery and vein. This area is triangle of Dohm, then here we can see this is triangle of pain area, this is deep ring, here is the inguinal ligament area, and these are the nerves LFCN and GFN nerve. So, here we can see this is the inferior epigastric vessel is going, this is inferior epigastric vessel, here is the medial umbilical ligament, and in the midline this is the median umbilical ligament, and then this is the medial umbilical ligament of left side, and this all area belongs to bladder in between two medial umbilical ligament. This is the triangle of Dohm of the left side, this is the sigmoid colon, and sigmoid colon is little distended, and here we can see this is the IP ligament of the left side, and if we will go deep there you can see the peristalsis of the left ureter. So, this is the left ureter visible and here is the peristalsis. So, we will do the total laparoscopic hysterectomy with the suspension of the vault with the round ligament, and after that we will do appendectomy also because this patient has previous history of the appendicitis. So, we are using only 3 port and this is 4 centimeter lateral, we are taking the round ligament with the ligature. So, round ligament is over, after followed by this is fallopian tube. So, we are using one 10 mm port supraumbilical 5 centimeter above the umbilicus and two 5 mm port ipsilateral 7.5 centimeter lateral to the umbilicus and below, and again 7.5 centimeter lateral and below to the second port, that is approximately 2 centimeter above and medial to the anterior superior iliac spine of the left side. So, this adnexal structure of the right side is separated from the uterus and 2.5 centimeter further over the broad ligament, and then similar thing we will do on the left side. So, this patient is approximately 45-year multiparous woman with the abnormal uterine bleeding with the grade 1 uterine prolapse. So, we have given option of the TLH with the sacrocolpopexy also, but we do not want to have the mess. So, we will do the suspension of the round ligament and in this case we have to do appendectomy also at the end of the surgery. So, appendix was inflamed one time and then once the ultrasound was done, then it was retrocecal appendix was found, and very long appendix was found in this case during the previous appendicitis. At that time conservatively it was managed. So, now this is the anterior leaf of the broad ligament and this is opening the UV fold, and the assistant is keeping the uterine manipulator uterus completely retroverted. Left hand is stretching the peritoneum, colpotomizer is pushed. Here we are using Mangeshkar uterine manipulator, and then you can take the anterior leaf of the broad ligament completely. Left hand has a lot of role in laparoscopy because it will, once it will keep the peritoneal anterior leaf lifted and stretched up, then your dissection with the harmonic will be very easy. Cranial traction is also very important, and lateralization of ureter. Here we are not using any ICG or infrared ureteric catheter. Most of the time we use ICG or infraureteric catheter to visualize the ureter, especially in the difficult cases, but here we are not using. So, lateralization of bladder pillar is also over. You can see vagina is visible like a pearly white background with the criss-cross pattern of the vessel, and bladder pillar is also lateralized either side. So, this is important so that uterine will remain, pedicle will be thin and you can coagulate. Now, this is the posterior leaf of the broad ligament. Again, similarly, left hand should keep it stretched and we will open the posterior peritoneum. Uterus should be at 1 o'clock position and it should slowly move from 1:12 and 11 o'clock position. You have to be careful that when you are separating the posterior peritoneum, the harmonic tip should give inferomedial traction and the tip of the harmonic should not touch the uterine artery or vein, otherwise a very dirty bleeding will start because it will puncture it. So, slowly from left side to right side, this is the posterior peritoneum is getting opened and now uterus is at 11 o'clock position, and then we will continue similarly to the right side. So, in this patient hysterectomy was very easy to perform because it was a very loose ligaments were there, and uterus is also, all the previous deliveries were vaginal. So, now we will take the uterine artery. This is the uterine artery of the left side and uterus is looking at 3 o'clock position, so that once you will do it, you will have the proper vision, and this is the uterine of the left is over. After that, we will take the uterine of the right side. Assistant role is crucial here because if you are doing only by 3 port with the ipsilateral, then you need a good traction contralateral so that you can take the uterine artery sufficiently. Ideally, for the beginners, the right side of the uterine artery, they should make one contralateral port and they should take this side of uterine artery from opposite side. So, it is over. We can see uterine is bleeding, but we have the nice peritoneal skeletonization, so you can easily catch the uterine. That is why opening the peritoneum is important, because if peritoneal folds are open and if uterine bleeds, the lumen of the uterine can be very easily visible and you can easily stop those bleeding. So, now the dissection part is almost over. Now we will start colpotomy. So, again this is harmonic scalpel and which is doing colpotomy. While you are doing colpotomy, all around it should be rotated and slowly colpotomy should continue. During that colpotomy, be careful that assistant should synchronize your movement of the vibrating jaw of harmonic, and you should keep the harmonic scalpel, the jaw open, because if you will keep it closed, then Teflon tip of the harmonic will cut. So, this is slowly anterior colpotomy, and it is also very important that the assistant should give the maximum cranial traction possible, because if vagina is stretched, you will be very easily you can cut it. So, this is anterior leaf of the vault and now contralateral side. So, total laparoscopic hysterectomy has not taken any time, hardly within 15 to 20 minutes you can finish the TLH, because this was a simple case. So, it is done very fast. So, it is over. Now, uterus is pulled out with the colpotomizer. Now, we are doing tubectomy here, and this is the right side of fallopian tube which is getting removed, and vagina is packed by one of the sponge in the globs, and this is the stone holding forceps which is pulling the tube and it is taken out. So, we will remove the tube of either side, we will not remove ovary, ovary is left behind and both the tube is getting removed. So, it is now done. After that, we will take the suture and start closing the wall together with the suspension of the round ligament. So, first we will take a bite on the right round ligament, and after that this is anchoring the anterior vagina, but the bite will be taken the posterior uterosacral ligament and posterior vagina is taken together. This is taking a bite on the right uterosacral together with the posterior vault. And then this is the anterior vagina. So, we will take 3 bite. This is the first one on the right corner, after that second one in the middle, this is posterior, including epithelium. Taking epithelium is important so that you should not have granulation tissue formation. And it is getting little not very tight, but you should progress the suture. And now this is the left uterosacral ligament together with the left posterior vaginal vault and then anterior. So, this is the last one. After that we will take the left round ligament, so that when you will pull it, it will all shrink like a purse string. Now, this is the left round ligament, and then needle end of the thread and the tail of end of the thread both will be pulled. This is needle end and here is both is pulled. You can see vault is suspended now, and now here we are using tumble square knot. Tumble square knot has the advantage that if you have a suture under tension, then also you can slide it better. So, initially you have to keep the suture loose, and once you will make a square knot, then you can tumble one of the length and you can slide it. So, that is very good knot. This is called tumble square knot. Tumble word means falling straight. And now this needle end of the suture is getting straight, and now it is sliding. It will slide, and after sliding you can take again further bite to the right side and it can be slided further. So, this knot is here we are using peritoneum of the bladder to cover the vault, and posterior as well as anterior both the peritoneum you will take. So, generally in normal TLH we do not do that, it is not necessary, but here we will do it so that we can cover the entire stump. So, this is a sliding knot which will make a very beautiful under tension also it can pull. This is again posterior peritoneum and followed by anterior one. Care must be taken that only peritoneum should come in the bite, and accidentally you should not prick the ureter. So, this is the peritoneum of the posterior peritoneum of the left side, and all is sutured together. So, it will cover the peritoneum also nicely, and after that we will terminate the suture. So, this is the suspension part of the surgery. And it is done. After that we will cut the suture, and then first take the needle out, and then we will perform appendectomy part of the surgery. And with the same port, however, with the same port it is not ergonomically correct. We can see this is a retrocecal appendix, tip of the appendix was not visible. So, we will start from the base itself, because tip was completely subserous and it was going retrocecal. It was a very long appendix, approximately 10 centimeter long, unusual type, and it was tip was buried in the subserous area and it was going subhepatic towards the liver. So, slowly we will go antegrade. Normally appendectomy is performed by retrograde, but here this is, we can see this is ascending colon which is coming in front. Our manipulation angle is very less here. We can see the manipulation angle of both the instrument is hardly 10 degree, almost parallel, because these ports were for hysterectomy, not for appendectomy. So, that is why it is little bit struggling, because if you want better ergonomics, then you can make one port in the right hypochondrium or suprapubic, then it will be much better. But because our both the ports are ipsilateral, so that is why manipulation angle here is wrong. But we do not want to give extra port to the patient. With little struggling, we are planning to perform with the same port. We can see appendix is altogether buried below the peritoneum and going towards the liver. So, it was a very long, and this type of appendix you cannot do retrograde, you have to start first from the base and then go to the tip. Sometime here extracorporeal knot for continuous structure is a better option, and you can tie the knot first at the base and then disconnect it from the base and then go towards the tip. But here we are not disconnecting, because it is at this moment of time it is going smoothly, but if we will see that a struggle started, then we will disconnect it first. We should must try to get the entire appendix up to the tip. We can see here on the right extreme, the lower lobe of the liver of right lobe is visible. On the right lower corner you can see the right lobe of the liver is there, and then you have a gallbladder also. So, it is almost reaching to the hepatic flexor of colon. But luckily here tip of the appendix was found, and then it was separated. So, patient has previous history of episodes of appendicitis, that's why we are removing it. And how it looks like, it is obvious that it might be creating the pain to the patient, because it is not a normal situation of the appendix. Do you know, harmonic is good in the sense, if we would have used the bipolar or hook, it was difficult, but harmonic is making this surgery of appendectomy easy in spite of a wrong port position. So now it is clear, entire appendix up to the tip is free, it is very long, you can see. And after that we are using Mishra's knot here. So this is the knot, that is a pre-tied loop, and you can pass the one grasper in the loop, then pull it out, and then we can slide it to the base. So we should keep the tip of the knot pusher over tinea coli and then tie it so that it should go completely to the base. And Mishra's knot, only one knot is more than sufficient, and then you can cut it, and then appendix will be separated. After that, to remove the appendix, we will use the 10 mm port. So telescope is changed to 5 mm, and this is the claw forceps from the 10 mm supraumbilical port, and holding the appendix longitudinally and then taking it out with the supraumbilical port. So thank you very much for watching this video. Have a nice day.